Well, good, Danielle.
Very good. Thank you. So hello, everyone. I do want to welcome you all to our annual, what we call our Network Council meeting. And this is really membership of all of the dialysis facilities and transplant centers. You are all part of the Network Council, if you didn't know that already. And we come together and we're talking about the CMS priorities and the goals and quality improvement activities that are occurring from May until April of the next year. That's really what's called our contract cycle. We'll explain that a little bit more. But we're here to talk about what those national initiatives are and how all of you really play an important role in that, in implementing those activities. I'm Danielle Daly. I know you're not seeing me, you're hearing me, but I'm one of the executive directors with the IPRO ESRD network program. I'm very happy and excited to welcome you all to this meeting. I want to tell you a little bit about some meeting reminders. The WebEx will be recorded and the slides will be made available on the network website. We actually have a little tag that says events and a drop down that says meeting materials, and that's where you'll be able to find it. Also want to let everybody know that the lines have been muted, and this is really to eliminate any background noise. We're expecting about 800 people to join this call, but we do ask that the attendees be present and engaged throughout the entire presentation. Be prepared to actively participate by commenting in the WebEx chat. We want to hear you. Please try to send everything to all panelists or all hosts and presenters. We have several presenters on the call. And that if you have any questions, please put them in chat throughout the webinar. You can submit them at any time because we will be viewing those throughout the presentation and try to provide some feedback. We also want to let everybody know that there will be polling questions conducted throughout the webinar today, and your feedback is extremely important to the network. If you don't see the polling box on the right-hand navigation bar, please click View and then Panels, Manage Panels, and then select Polling. So I know that sounds like a lot to do, but if you're not seeing polling, we want to make sure that you're able to participate in the polling questions. I want to also go through the objectives of the webinar today, and that we're here to provide an understanding of the scope and role of the ESRD networks under IPRO. We do want to explain all of the national initiatives that are outlined in the executive order of advancing American kidney health, the conditions for coverage, and our ESRD statement of work. It provide an in-depth knowledge about social determinants of health and really more specifically how they impact health equity. Also provide an overview of the IPRO Learn system, which is our virtual learning management system, explain how to access and utilize the ESRD data systems and quality reporting, and then really include more information about those national initiatives with goals, education, and interventions for the quality improvement activities, how to foster patient and family engagement, and how to positively impact the patient experience of care. And then lastly, we want to share information on what CMS expects for emergency preparedness and the management protocols required between the network and also dialysis facilities. So with that, I am going to have my colleague Sue Capone take over and talk all about the ESRD program administration. Sue.
Good afternoon, everyone. Hi, I am Sue Capone, as Danielle introduced me. I want to welcome everyone to the Network Council meeting and thank everyone for attending. We know how busy you all are and appreciate your time. Let me just move my slide. Oops, sorry. Okay, so I'm going to give you a little bit of background about IPRO. We were founded in 1984. We've been in business almost 40 years. We're a not-for-profit organization, and most of our work are government contracts, and it's mostly federal contracts and some state contracts, and a lot of our work is with CMS. What we feel sets us apart from other organizations is our staff, and we have a great track record. We've been doing federal work as the ESRD networks since 2006, and with our Quinn QIO work, close to 30 years, 35 years. Our headquarters is in Lake Success, New York, but we also have other ESRD offices in Hamden, Connecticut, North Carolina, Morrisville, North Carolina, and Beechwood, Ohio. So this is what the Medicare-funded ESRD organizations look like. Each organization works to improve the quality of life for ESRD beneficiaries. Each of these regions or ESRD contracts, there are 18 contractors that work in this area, and each are put on the same time frame of a 5-year contract. So ESRD networks work as a bridge between the federal government and the ESRD providers and patients that they serve. So this is a breakdown of the IPRO territories, I'll say. So we hold 4 of the 18 ESRD network contracts, Network 1 being the smallest ESRD network. As you can see there are the demographics there, about a little over 15,000 patients, a little over 200 facilities and 15 transplant centers. And I'm not going to read them all off, but you can see one of the largest networks is Network 6, with almost 800 facilities and 50,000 patients and 10 transplant centers. Also a very large network is Network 9, 651 facilities, which is very large with 30,000 patients. And Network 2 falls somewhere in the middle with about 350 facilities and dialysis patients under 30,000. So as a program, we oversee about 25% of the dialysis population across the country. So our mission statement here for the ESRD program is to promote healthcare for all ESRD patients that's safe, effective, efficient, patient-centered, timely, and equitable. So I want to talk a little bit about what our statement of work. So our contract cycle is, like I stated earlier, is a 5-year contract. And the way it works is we have a base year, which we just completed, and then we get 4 option years, and we're evaluated each year. And if the year is successful, then you go on to have another option year. So the contract cycle began June 1st of 2021, and it goes to April 30th, 2026. And we are currently in option year 1. So all the work that we do ties to the National Quality Strategy and CMS initiatives. And they're all driven to improve the lives and the care that patients, that ESRD beneficiaries receive. All of our QIAs are incorporated into one or more of the 16 strategic initiatives of CMS. And when you get a copy of this presentation, you can follow those initiatives at that link. So we deploy interventions, we target patients and dialysis providers and other stakeholders. We focus a lot of our QIAs, or all our QIAs, on some very targeted areas now, and that is focusing on health equity, rural health, and vulnerable populations. Again, we are grounded on the concepts and design of the Social Security Act, HHS Secretary Priorities, the Executive Order for Advancing American Kidney Health Initiative, ETC payment models, and the ETC Kidney Transplant Learning Collaborative. We are all tied together with similar goals. So about the current statement of work that started last year, we support achieving 25 quality improvement data-driven goals. We have 8 advisory groups with supporting coalitions, conducting 6 PDSA cycles. Another goal that we have is 20% of our network service area, we do a data audit annually. Networks also, we deploy interventions. I already said that bullet. And this is a little repetitive. Next slide. So the network works with an advisory committee in each QI focus area. Excuse me. And in that advisory committee, we review data, best practices, we discuss barriers and mitigation strategies. And using the input that we receive from that advisory committee, we then pick a group of facilities to work with as a community coalition. Every facility in the network, separate from this community coalition, is working on the same CMS goals with the network. But the community coalition facilities work through a different process. That group conducts an RCA and a PDSA process to test the new interventions and provide direct one-on-one feedback and determine mitigation strategies. So the successes of the community coalition facilities help to share best practices and spread them to within the community and throughout the network, building a community of practice which ultimately improves the quality of care for ESRD patients. As a reminder to everyone that works in a dialysis facility, I'm sure is very familiar with the conditions of coverage because that's how you're all certified. So the Federal Register cites that network-specific goals and the dialysis facility responsibility is toward working with the network toward achieving those goals. When the state comes in to do your certification, they usually utilize these goals as a guideline for the evaluation. They'll ask about, if you're working on transplant or if you're working on whatever initiatives, the goals that we're working on. And those goals that we're working on are achieved through these quality improvement activities that we share with you all. So participation in the network of activities is a condition of approval to receive Medicare reimbursement for the provision of ESRD services. And of course, CMS states that failure to comply can result in a sanction. So our work is aligned. We all want the same thing here. So the network providers are doing the same work as the network, but just we're going at it a little differently. So our network role is to improve the quality of life. That's our goal, by reaching goals and outlined by CMS for the ESRD population, improve the lives of beneficiaries, ensuring patients have access to care and patient experiences of care and the atmosphere of respect and safety in the facility, maintain data quality of national data sets, and support the ESRD community during emergency events. On the other side of your role, or the provider role, is that to work with the network to reach goals by CMS in all areas of quality improvement, provide a dialysis setting that's safe, respectful, and ensures access to care while you're providing care. Support accurate and timely data entry into EQRS and NHSN, and collaborate with the network to ensure all patients receive ESRD care during an emergency event. We know that you take care of your patients during an event, and we're here to support that in any way we can. And I'm going to pass it to Danielle Andrews, our Project Manager Health Equity Specialist, to talk about our health equity work. Danielle?
Hi, everyone. Do I have the book? Okay. So I'm going to talk with you about health equity. So before we really get started, I'm going to do like a health equity check-in. So a poll should come up, and the poll is going to ask you, do you wear glasses?
And Danielle, that poll's now open. All polling questions will be open for 1 minute, so please get your answers in, and I will share the results.
Yeah.
We're about halfway through, just about 30 seconds left to get your answer in. About 10 seconds left. I'll close that poll, Danielle. If you want to continue on, I can post the results.
Okay. So once that poll closes, we're going to open this poll. This poll, and it's, have you ever had to order specialty frames? Frames, not lenses. And that poll should open momentarily.
And it's just taking a second because we got a lot of folks on the line. So that poll's about to come up. And same thing, we have about a minute for that poll will close. Nearing that 30-second mark. And we're getting to those last 10 seconds. I am going to close the poll and then provide those results.
So up on the screen, we have pictures of 3 different people wearing glasses. I want you guys to notice how the glasses sit on their face. And this is a lesson in terms of health equity in the sense that glasses are created to sit on the face of individuals who have nose bridges. Essentially, if you are indigenous to a warmer climate, you have wider nostrils and your glasses will rest more on your eyebrow ridge, meaning that the glasses can't sit on your face and they tend to slide off. They are made to sit on the face of people who tend to be of European descent. And this is just to highlight how some aspects of healthcare are inequitable, especially since the majority of the individuals who answered this question do wear glasses. So, and then our last polling question is, do you think health inequities exist within an average dialysis facility?
And again, that question is open. We have about 45 seconds left. Lots of answers coming through. We're about halfway there. All right, about 15 seconds. I'll just give it a little bit more and then I'll close and share the results.
Okay, what is health equity? According to the World Health Organization, health inequities are systemic differences in healthcare outcomes. Equity is the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality. Health is a fundamental human right. Health equity is achieved when everyone can attain their full potential for health and well-being. Health inequities are differences in health status or in the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. So, social determinants of health. According to the World Health Organization, again, health inequities are systemic differences. Social determinants of health are conditions and places where individuals live, learn, work, and play that affect a wide range of health and quality of life, risk, and outcomes. So some examples are going to include safe housing, transportation and neighborhoods, racism, discrimination, and violence, education, access to education, and access to a certain quality of education, job opportunities and income, access to nutritious foods and physical activity opportunities, polluted air and water, language, and literacy skills. So this is just focusing on social determinants of health and access to care. And this is highlighting where some of the dialysis facilities are located within the United States. And there's a larger density along the coastal states and states on the eastern side of the country. There are individuals who may not even have access to an ESRD facility in their community, in their region, or even within their state. So large urban and rural counties see lower percentages of patients receiving pre-ESRD nephrologist care compared to suburban and medium-small urban communities. Females, white, non-Hispanic, and older patients are more likely to receive pre-ESRD nephrology care. Low socioeconomic status and low educational attainment are associated with a higher prevalence of ESRD. And low educational attainment, being of African American race, poverty, and unemployment are all associated with lower rates of kidney transplantation. So there was a study done that really wanted to look at which demographics and social factors predict the likelihood of receiving a kidney transplant. And the factors associated with the lower probability of receiving a kidney transplant is again being of the Black race or of African descent, being of an older age, having a lower income, having public insurance, having more comorbidities, a greater religiosity, less social supports, less transplant knowledge, and fewer learning activities. So I want to open it up to another health equity check-in. Have you ever heard or discussed intersectionality?
And the poll is open. We have just about 45 seconds left. And about halfway through, if you haven't gotten your answer in, please put that in now. I'm starting to see answers slow down, so just going to give it another second and I'll close that poll, Danielle, and post those answers.
So the concept of intersectionality describes the way in which systems of inequality based on gender, race, ethnicity, sexual orientation, gender identity, disability, class, and other forms of discrimination intersect to create unique dynamics and effects. All forms of inequality are mutually reinforcing and must therefore be analyzed and addressed simultaneously to prevent one form of inequality from reinforcing another one. So another health equity check-in is, have you previously utilized intersectionality to develop patient-specific health plans?
And that poll is open. And we're about halfway through. I'm seeing a bunch of answers come in. Thank you for your participation. And we have about 10 seconds left. I'll close that, Danielle, and then post those results for you in just a few moments.
So a large percent of you actually said no. So here I have intersectionality in the web of oppression, and I'm really utilizing the web of oppression just to show you how there can be different identities that intersect and kind of shape the way a person views the world and the way they engage in the world. So a person can be of two races. So in this case, this person is African American and Native American. They are female, they are the working class, they're US born, English is their native language, able bodied. In terms of spirituality and religion, they're Buddhist. And then in terms of sexual orientation, they identify as queer and pansexual. And all of these factors will kind of shape some of their behaviors, the way they think. And this individual may need a patient specific treatment plan to make sure that we are acknowledging all of their strengths and some of their external stressors that we may not have. So the network did do a preliminary survey to some of our facilities, and this is just a small subset of the answers. So of the individuals that were sent out, 348 facilities responded. 26% of the facilities said patients do not have a primary care provider. 18% of facilities have stated that they are located in food deserts. 85% say note financial reasons as being the largest barrier identified by patients to following renal, diabetic, cardiovascular, prescribed diets. 61% have noted as transportation as being the largest barrier identified by patients to becoming active and remaining active on the transplant list. 71% have noted limited space to host home therapy supplies or setup as the second largest barrier by patients on transitioning to home therapies. And 77% of facilities say that their patients experience mistrust in healthcare system and medical racism as a top reason for vaccination hesitancy. Do we have any questions? Please feel free to utilize the chat to let me know if you guys have any questions.
So Danielle, I do see a comment in chat right now that says, with all this data, what is the plan from the ESRD network to advocate for the patient regarding health equity? If you want to be able to address that.
So essentially the plan is for the network to identify overall some of the more generalized health equity barriers and to create interventions that will specifically address these barriers. There is also a consensus where we will address some of these barriers with CMS as well to see if there is a way that we can remedy some of these issues, because not all of these issues are fixable by facility or by the network. Do we have any other questions?
I read the email that you sent out.
No, I'm not seeing any more in chat, but just again, just a reminder to folks, if you do have questions throughout the presentation, please drop them in chat and please use all panelists, and we will make sure that those are addressed here. I'm just seeing one more comment, that pretty compelling data, and sadly that they are on a fixed income and struggling financially. So we do recognize that that is contributes to health equity, and there'll be some resources and information shared throughout the contract cycle. Okay, I am going to move things over. Thank you, Danielle. I'll move things over to Svetlana Myolkin, who is our Director of Information Management, and she's going to tell you a little bit about IPRO Learn and all of our ESRD data systems. Svetlana, you have the ball.
Thank you, Danielle. Can you hear me okay?
Yes.
Thank you. Okay, most of you have already become familiar with IPRO Learn, but here's some important reminders about it. IPRO Learn is a centralized one-stop shop for facilities to self-report data to the network, to access the shared tools and resources, and to learn about upcoming events and deadlines. All IPRO ESRD networks facilities are required to use IPRO Learn to complete monthly QIA activities. By completing these activities, the facility will meet the network participation requirements listed in the conditions for coverage, which state that facilities are expected to collaborate with the network to reach the CMS goals for improving the quality of life for patients living with kidney disease. In addition to facility requirements, IPRO Learn also provides users with the ability to earn CEs and for patients to collaborate with the network and learn about peer mentoring. And again, multiple staff members from your facility can be involved in completing these activities and sharing and spreading the knowledge and best practices that you pick up while in IPRO Learn. To log in, facilities should use the login and password assigned by the network. This login information, again, can be shared between facility staff so that different staff can complete the different activities on topics they are either most experienced in, or they can access resources on topics they want to know more about. Having one login for the facility also prevents multiple staff from completing the same activity multiple times. This login information should never be changed, or the facility can get locked out and not receive credit for completing the activities. A second type of login for IPRO Learn is if the user creates a personal account to access the CE course or the peer mentoring training. You will not have access to the facility activities if you log in with a personal account, but it is easy to log in and out and switch accounts as you find that you need to. Once you log in, you will see this dashboard, which has all the different options for you. In the top right corner, you will see what account you are logged in as, and you could also click right there if you want to leave and switch to a different account. If you click on the picture or link for the ESRD Facility Quality Improvement Collaborative, you will access the facility activities that are not specific to you, but specific to your facility. Here's what it looks like when you go in there. At the top, you will see all important announcements and upcoming events that we think you and your team should know about. And then you will see the monthly required activities and due dates for your facilities. Different facilities have different activities listed here because some may be on a coalition at any given time, or you may have already been on a coalition and you no longer need to do a specific activity. So make sure you review what's listed here for your specific activity and do not assume that it is the same activities for a different facility you may be affiliated with as well. But please know that once the due date passes, you will not be able to return to complete an activity that you missed. This is because we download the responses, we analyze them, and we report them to CMS. After we report them to CMS, we do not reanalyze the data again, and your facility will remain on the incomplete list, unfortunately. Also in this course, you will see the toolkits. They're listed, there's a little sample of them listed below, and also shortcuts to them in one of the blocks. And these contain the proven and vetted best practices that our team has gathered from national, local resources, and also that we developed internally at IPRO. Please review these toolkits and share the resources, and also please provide feedback to us on what you found most useful and helpful in helping your facility meet the CMS goals. Please take time to also explore these other blocks that you will see on the right. There's other important information available to you, including the discussion boards, also patient opportunities, and other shortcuts to websites that we know you will use and that you need throughout your work. Remember, please, that IPRO Learn is the main place for your facility network participation requirements. Share the login with the designated teammates that can help you complete all the activities. Lastly, about IPRO Learn, this is where, let me see, where am I? Excuse me. This is where you will see what is required of you, and you can come here at any time to get anything done that you need. You can also access it 24/7 and again, share it with your team. Once somebody completes the activity, it is marked as complete and you do not need to return to it. I'm backing up to the dashboard again to show you what the other sections look like in IPRO Learn. Here is where you would click to access the patient portal. This looks kind of similar because it also contains announcements, training opportunities, and activities for the patient representative. Please encourage them to get involved and participate in these activities. Lastly, here is where you would click if you wanted to complete some of the CE activities. We hope to have more of them posted here throughout the year, and you would again need to create a personal login to access them, and they're available to you for free and 24 hours a day. Next, I will quickly go over some EQRS information and why the data in EQRS is so important to everything that your facility does in terms of quality improvement. As you know, CMS is tracking completion of admissions within 5 business days, 27/28s within 45 days, and 27/46s within 14 days. This is still an ongoing requirement in this coming year, and the network will continue to send out monthly reports on your facility's progress. This is why it's important to have your current personnel updated in our system so that we can send you these reports. And I hope that you all know that form that's available. If you have trouble admitting a patient into EQRS, just submit the possible duplicate or near match form and we will admit the patient for you as quickly as we can. Admissions and forms are not the only important data in EQRS, though. Maintaining accurate and timely patient information determines your facility's progress towards meeting CMS goals for the quality improvement activities. If the data is not correct in EQRS, then the facility cannot get credit for their hard work. We strongly encourage facility staff to use the available resources and to complete the assigned activities in IPRO Learn that focus on data accuracy for any and all of the QIAs. It is also very important to train all new staff on the available resources and to review all the data reports that we send out throughout the month that may include cleanup activities or just a status update of where your facility is relative to your goals. Also, please become familiar with the IPRO knowledge base and Fresh Desk. Facilities would greatly benefit from exploring the resources we have here because we've created step-by-step guides for all the questions that we've received so far from facilities. So we're confident that you could find what you're looking for in here, but if you don't, we would love to create that resource for you. So please explore, access what we have, and let us know what you think or what you would like to see differently. We also have the ticketing system available on this site where you can submit your request and any of our data team can correctly either triage the question to the right person or take the time to investigate your concern and provide you with a detailed answer as quickly as we can. And lastly, please make sure you maintain your personnel using our IPRO contact management system. The login is IPRO ESRD, all capital letters, and your password is your facility CCN. So please make sure that everybody there is correct and current so that they can receive our reports and our announcements and invitations. And now I will turn it over to Deb DeWalt for the quality improvement section.
Svetlana, before we move over to Deb, I just want to tell everyone when this presentation becomes available, all of these hyperlinks that are in the presentation will work for you. So for example, this knowledge-based job aid that's down below, when you get that presentation, please access that link if you do have some questions about what's presented here. And there are many links throughout the presentation. I do have two questions that I also want to go to that were in chat, and I believe one of our team members, Andrea Bates, began to answer it. There was a question about CEs being available for social workers. Right now it lists only RNs, LPNs, dietitians, and dialysis technicians, and that's for IPRO Learn. So I know, Andrea, thank you for putting that response. Deb, I don't know if you want to expand on that anymore, because I know you might be having some challenges.
Unfortunately, I can't see what Andrea wrote, but I am the coordinator for contact management, our management, and I can say that we are approved provider by the California Board of Nursing, and social workers in all of our 13 states will not accept that contact hour from them. So we are looking into it, but because there are 13 states, like Andrea mentioned, and all the 13 states have different requirements, it's quite laborious, but in our ever quest for quality improvement, we, we're trying, but it takes a lot. And if there's anybody from social work who wants to create maybe a work team to see if we can get that done, I'm open to that. That would be very helpful.
Thanks, Deb. And I do have one more question here. It is related to health equity, and it's stating that for transplant, can the network create a list of all transplant centers that work with patients who are not documented in the U.S., as well as the transplant centers that will take patients who do not want to pursue a COVID vaccine? And I know we have Caroline Sainer on the phone. She is our lead in that area. And it kind of crosses our health equity and also transplant initiative. Just want to put that out there. Not sure if Danielle or Caroline want to answer if this is something we can look into.
Hi, yeah, I responded in the chat, but I'll go ahead and say it here if you can't see the chat. We can look into doing a scan related to undocumented patients as well as vaccination requirements if that is something that our network service area is interested in, definitely.
Great, thank you. And Deb, you do have the ball, so you are free to advance the slides.
Okay, everyone. My name is Deb DeWalt, and I'm the Quality Improvement Director for the IPRO ESRD Network Program. And the Quality Improvement Department is directed by Victoria Cash and has 8 dedicated professionals, each specializing in 1 or 2 of the objectives and key results. The team is working currently to achieve 25 measurable goals and collaborating with 70% of our network service area during the current coalition to achieve these goals. I'm going to do a review of each of the OKRs and to refresh your memory. And if you have any questions, I ask that you put them in Q&A or the chat. I cannot see them, unfortunately, in chat, but I can see Q&A. And our dedicated quality improvement team will work to answer those questions. So there's 5 different objectives and key results. The first is to improve behavioral health outcomes, which is regarding the remission of the diagnosis of depression in ESRD patients. Goal number 2 is to improve safety and harm, which reduces catheter infection rate in patients receiving home dialysis within nursing homes. Goal 3 is to improve high complex chronic conditions, and this goal includes both home and transplant access and increase of those modalities, and telemedicine and vaccinations. Goal number 4 is to reduce hospital admissions, readmissions, and outpatient emergency room visits with an expected reduction in all areas. Goal number 5 is to improve nursing home care in low performers, which includes nursing home patients receiving the home modality in the nursing home that they reside and to decrease their blood transfusion. There are also strategic requirements that are interwoven throughout all of our OKRs and an expectation throughout all of the projects, and that is to improve patient and family engagement, and specifically the 3 measurements we're looking to increase is the number of facilities that successfully integrate patients and families into their QAPI meeting, to increase the number of facilities that successfully assist patients to develop a life plan, and increase the number of facilities that successfully develop and support peer mentoring. Next slide. Our next OKR is led by Andrea Bates. Many of you know Andrea as a quality improvement, as the patient services director in Network 9. She's moved on to be part of our quality team and is working to increase remission of the diagnosis of depression. Her QIA revolves around increasing the amount of patients accurately screened for depression by 30% this year, increasing the percentage of patients with depression receiving treatment by 20%, and ensure 80% of all facilities report results of monthly screenings in EQRS. EQRS is the data system for this project, and the activities include conducting an RCI, developing and sharing tool-specific services on IPRO Learn. Andrea asked her facilities to do a root cause analysis, and the top 3 root causes where facilities are planning their PDSA from are referrals and access to mental health care, stigma associated with mental health diagnosis, and others, which is a miscellaneous category, which would require the facility to work with Andrea to develop a more specific plan to their needs. The barriers to this project are in the right-hand graph at the side of the screen, and the most common 2 are access to mental health services, and the stigma, once again, is recognized as a barrier to working this project within the facilities. The resources for this project are located on IPRO Learn. You're going to hear me say that a lot. The first two are for patients to help self-recognize and prepare a discussion with their physician regarding their mental health and signs and symptoms of depression. And we also have toolkits that have been created by patients for patients on our toolkit on IPRO Learn as well. We encourage you to check these toolkits to assist you in the work of these projects. The second OKR is improving patient safety and reducing harm in improving nursing home care. Our project lead for OKR 2 and 5 is new to the team. Kathy comes to the network with over 30 years of dialysis nursing experience and has provided care within acute and chronic facilities. Her work in this OKR revolves around reducing catheter infection rates in nursing home patients who receive a home modality in the nursing home that they reside. The goals for this project are incremental. We do have services that provide nursing home care to our residents with a home modality in Network 6, 9, and 2. We do not have any in Network 1. So there's a modification in our contract, and since we don't have any of these programs or services identified, Kathy will work with 6 in-center hemodialysis facilities within Network 1, a total of 80 nursing home patients total, to decrease long-term catheter infections within that smaller population. Her goal this year will be a 6% reduction. For her work with OKR 5, her goal is to decrease the rate of blood transfusions in the ESRD patients dialyzing using a home modality in the nursing home in which they reside. Once again, we do have patients in Network 2, 6, and 9 that we will be working to reduce blood transfusions. And as you can see, we did not have any blood transfusions identified in Network 1, and both Network 2 and 9 met this goal last year, and we will be working extensively within Network 6 to improve the reduction of nursing homes. So these are some of the resources that Kathy has on the IPRO Learn Toolkit. I want to draw your attention to the one in the upper right-hand corner of the slide, because it is an EQRS requirement that facilities review their patient demographics to update information about patients' addresses for patients that are residing in a nursing home should reflect the nursing home, and also to make sure that if a patient in a nursing home or not in a nursing home is receiving a home modality, we need you to identify where that location setting is. This job aid is available on IPRO Learn. So this is a pretty long goal in OKR, and the first part of the objectives and key results for high cost and complex chronic conditions is home dialysis. Last year, you can see within the network system that no one reached their goal from moving incident patients to home. We recognize that there was a lack of infrastructure. We recognize there was a lack of staffing, and there was a lot of lack of outreach to the CKD community to interest them about going home as their first modality choice. The definition of incident patients in this project is not what you are used to. An incident patient for CMS in this project is a first day of dialysis that is spent on a home modality, not within the first 90 days. The second part of this project is patients using a home modality that are in an in-center dialysis facility that transition to home. And you can see that we did achieve success in our Network 1 region. And we had very large goals in network 6 and 9 because of the number that we have moved to home in the past. So we're trying to catch up right there. And network 2, we're working specially within network 2 as a special project to really increase home growth and interest. In the home project, there is also a tagline for us to increase rural patients' access to home modalities using telemedicine. We have received many questions for those of you in this project, and we understand your confusion. You were not asked to do an RCA. You were not asked to, join a community coalition call, but really these facilities that are in this project are those facilities that we have identified a rural patient that is on a home modality, and every month you will receive a scorecard to tell you what patients are still eligible for telemedicine visits. The goal is that 1 in 3 of the clinic visits for the rural patient should be minimally offered as a telemedicine visit. This is a CMS objective to use telemedicine in almost every modality and every inch of the healthcare system, and they're really trying to perfuse this into the home modalities in the ESRD populations. So if you have any questions, you can contact me or write a help desk ticket to clarify your participation in this project. Resources for home include a continuing education program that is an IPRO Learn. One of our barriers and tasks brought to us by our advisory committee was to increase staff awareness and education about home modalities so that they could better educate their patients, and we created this programming to fulfill that need. There are many interesting case studies in this Contact Our program as well that may stimulate your interest in who should possibly or who could possibly be a candidate that you might normally overlook. Next slide. Other resources on our IPRO Learn for Home include a campaign related to home modalities at different levels of interest for patients. Some are flyers, some are brochures. All of the materials in the Healthy at Home campaign with the red banner on the right also have staff guides to assist you in using them with patients. The 2 resources on the left are patient and facility checklists that we have created to allow patients and families to engage with their clinics in a telemedicine visit. Next slide. Home modalities as well as transplant have been sending out performance scorecards or report cards. In the upper right of the report, you can see the benchmarks for home transitions, home incidents, transplanted patients, and waitlisted in the upper right-hand corner. The benchmark for the home modality project is listed at the top of that page, and you'll see that from baseline, this facility put on 5 patients. Our projected goal for them in this past year was 6. Year to date, how many they put on, how many they still needed to reach goal, what their percentage rate of increase was, and where it, then they could take that number and look at the top box and see their own benchmark. We are going to increase some of the clarity on these transplant and home scorecards, and you'll be looking for a better and new improved product in July. Carolyn Sanner is new to our team. She is an RN, and she is got the really big task of working with 52 transplant centers throughout the network service area. She's mastering learning all of them, and getting in touch with them, and also managing our transplant coalitions within the network service areas. Last year that just ended in April, Caroline was successful in achieving goal in 3 of the networks, 6, 9, and 2, for increasing waitlisting by 2%. Network 1, unfortunately, did not make that requirement. This relative increase will increase every year of the contract. So we have to be forever vigilant and continue to put more and more patients on the wait list. These are some of the really valuable resources that are in our toolkit. One of the first ones is a tool to assist patients navigate through a transplant workup. It's a checklist that they could keep on the ready and have appointments signed off and tracked. We have a big push to improve our amount of living donation transplants. And this is a fact sheet that we have created to do just that. Many of you may have already seen Wait Less, Shorten Your Wait for a Kidney Transplant, which is a patient-facing resource, and a similar material for facilities on how to help their patients reduce the wait for a kidney transplant. This provides informational information on hepatitis C kidneys, high-risk kidneys, and how to do a big ask or a campaign for your own living donor. Once again, this is the home and transplant modalities report. The data that comes to you every month is not the total number of patients that you have waitlisted in your facility, but it is the amount of transplant waitlist additions and transplanted patients that occurred from your data from UNOS in the last month. You can compare your scores where your own individual facility lays against the benchmarks that are offered in the upper right-hand corner of that material. Also, Carolyn, being our tech guru, has very lovely included a QR code. And if you scan that code and you're not receiving these reports, you could go into our contact management system right now and update your contacts for your facility, and you will be sure to get all of the materials that you need from the network. I am in charge of the reducing hospital admissions and readmissions and ER visits materials, and I will say that all of our networks met the goal to reduce admissions. Network 2, 6, 1, 9, all of them met the goal for a 2% decrease in these admissions. Every year they increase by how much more we have to reduce, and this year it will be 5%. So we will be working with the network service areas to spread some best practices we've learned over the year. In readmissions, everyone except for Network 2, unfortunately, did not make goal. In the readmissions category, we were required a 2% decrease. Next year, it will be a 5% decrease. As far as reducing outpatient emergency room visits, all of the networks within our service area made this goal except for Network 1. I will point out that it was a very, very small measure that they did not pass by, and I'm sure that we can turn this around in the upcoming years, working with the Network 1 coalition and advisory group to make sure that we meet this goal. Once again, I do have a performance scorecard, as you can see here. We had lots of questions about what does this mean. This is a very hard project to translate to you because I'm looking at percentage points for your facility, but percentage points don't really translate into how many instances we ask you to remove. There was a lot of confusion about the Medicare fee for service. Those are the only patients that are in this project. So if you have a patient hospitalized that's a PPO, HMO, Medicare patient, They are not seen on this report. So to clarify and assist you in reviewing who was docked to your facility by Medicare based on claims data, we've now started providing UPIs for your facility to be able to review. And, you know, these UPIs are very good to review to see if you have a trend in patients that are going over and over again to the hospital or emergency room. Aisha Edmonds is our new vaccine and COVID-19 hospitalization reduction. She's really working to improve the vaccination numbers within all of our networks. She's battling staff and patient hesitancy. We're trying to get to a herd immunity. We're trying to make our patients understand that getting these vaccines is not just important for, you know, getting numbers up for COVID, but also for making them eligible for transplant, for keeping them out of the hospital. Vaccines are very important in the ESRD community. All of our networks, except for Network 1, reduced COVID hospitalizations from our baseline year by greater than 25%. We're very proud of this. We have to maintain this number throughout the contract, and we hope that this will disappear as our patients don't go to the hospital at a high rate. So we're working very hard to remove this work. Also, we had a lot of resistance this year about flu vaccine. The goal for last year was 85% of dialysis patients receiving a flu vaccine. In the upcoming year, it will be 90%, and 90% of staff to receive an influenza vaccination. We are very committed to getting these numbers up. I know it's a lot of documentation and several different applications, but everything that you do, we really want you to take credit for. So we hope that you are going to be reporting this at a higher level and capture as many vaccines as you can. As far as COVID and influenza vaccines, if they're given at the nursing home or outside, you can record them as given. And if they are doubly charted at both a nursing home or a skilled nursing facility, we are still required to document that same vaccine in our ESRD NHSN platform. We have many interventions and resources to capture vaccines outside of the facility. We've improved our vaccine pamphlet that we created several years ago to increase information about COVID on it, and we've also added COVID documentation to the vaccine record for patients to carry. I do want to draw your attention to the toolkit in the IPRO Learn. There's documentation information on both how to document vaccines in NHSN for healthcare personnel and for COVID for patients, and also on how to document patient vaccines in EQRS. Andrea is also working, she's a busy girl, to improve our patient engagement goals. We talked about those being increasing the amount of patients participating in developing a life plan with their IDT team to add some value to the regular care plan to include patient-specific and patient-generated goals. Also, are working to increase patients integrated into QAPI on all of the OKRs, and all of the performance should be shared in those QAPI meetings, and patients should be engaged. There are several great QAPI resources. Our biggest pushback on the QAPI was that facilities reported to us that they did not understand how a patient could be in a QAPI meeting because there's HIPAA involved. QAPI and patient care meetings are different, and QAPI does not usually have patient-specific information shared. So we invested some time and created a recording as well as a help with HIPAA, how to get your patients involved in QAPI resource. And we hope you really look these over and engage your patients in this meeting. Peer mentoring, we look to increase peer mentoring throughout the organization, and we're looking to grow peer mentors for being specialists in each OKR, or just even to help patients that are new to dialysis or old to dialysis achieve some quality of life and understanding of the challenge that dialysis presents to them. As you can see, we did grow our peer mentoring staff across all of our programs, and we're very proud of that. But there's really a lot of work to be done. And if you have a peer mentor that you can identify at your facility, once again, on IPRO Learn, there is a patient-facing portal, and if the patient creates a login, they can actually participate in our network-generated peer mentoring program. And at that, I'm going to turn this over to Danielle, and I will be reading the questions in the chat and answering all that I can. Thank you.
Deb, I do have a couple of questions in the chat, so I'm hoping that we can address those quickly. There's an individual who's saying that the patient depression screening occurs within the first 90 days of admission at their facility, and then again as needed on an annual basis. So if PHQ2 does not trigger a full PHQ9 assessment, so they're saying, should we be completing the depression screens on a monthly basis now based on the presentation? And will we be, and I guess I'm air quoting, in trouble if not? And then there's an addendum, same person, that says, also my screenings do not automatically batch over to EQRS. So I've been manually inputting depression screen results as they are completed. So I'm not sure, Deb, if you'll answer or if Andrea can answer that question about depression screening.
I can answer.
Yeah.
Can you hear me?
Yes.
Okay, good, because I'm not connected to my phone. So I responded to this person privately, then I realized I should probably respond to everybody. So first of all, to my knowledge, they're only required to be done annually, not on a monthly basis. And to this person who doesn't have a batch facility, I do believe that is a best practice. I know it's not feasible for every single facility, but I'm seeing more and more facilities tell me, because everyone's depression screening is due, if it's due annually, it's due at different times. So you're not going to be doing like a whole facility at one time. It's usually when they're people usually do it with their plan of care. So I have seen more and more facilities going into EQRS and putting them in manually because of batching errors and because of whatever's in the patient EMR is not getting batched over correctly into EQRS. But I can always, I will double check, and to my knowledge, it's only required annually, not monthly. So
I think that we may have misspoke on that slide, because it did say that ensure 80% of all facilities are completing a depression screening monthly. So we will clarify that with you all.
Thanks to you both. And then there is one question in the QIA that says, when you speak of decreasing in emergency room visits, is it any ER visits or just ESRD related?
It is all ESRD visits, regardless of the nature of the event. It could be a cardiac event, it could be an amputation, it could be a traumatic head injury. Unfortunately, if you are a 2728, if you filled out a 2728, you're an ESRD patient and they're monitoring all admissions. Can you reduce those? No, cannot. But that means what we should actually be working very hard on the admissions that we can thwart or change. There's always going to be an odd one out. It's something like how all of the infections in a dialysis patient need to be reported in NHSN regardless if they're related to ESRD or not. So unfortunately, the answer is yes.
Thanks, Deb. And for those who did not hear the answer previously about whether or not we are offering CEUs to social workers, the answer is not at this time. We are having some challenges with the type of certification that we have, but we are looking into ways to make that option available. So thanks, Deb. Really appreciate your time. And hello to everybody again. My name is Danielle Daly. One of the areas that I help support for our team is improving the patient experience of care. So I want to tell you a little bit about that. There are national initiatives as well. And the way we do improve patient experience of care, what we refer to as PEOC, is by resolving grievances and making sure that there aren't any barriers to access to care. So it's important that we are educating the patients and dialysis staff about what our role is and how we can do that or how we can assist. We also conduct a focused audit of all the grievances and access to care cases that our social work team encounters, and we try to find some trends that exist. And based on those trends, then we are going to develop some interventions or resources to help mitigate those trends. And then with the network's case review responsibilities, this could include anything from investigating and resolving the grievances to then even bringing in additional partners, maybe with the state health departments, to help in cases that are beyond our jurisdiction, and that we want to make sure that there are also any non-grievance access to care cases that have our assistance provided, make sure that patients are receiving care. And CMS views the investigation and resolution of the grievances and non-grievance access to care cases as an opportunity to focus on meeting the needs of the ESRD patients, as well as creating an opportunity for change, by listening and learning to the patients. It could be caregivers as well, their perspective. And then this change occurs when the dialysis facility understands the root cause of the grievance and then helps to implement steps to resolve the issue. And the steps that lead to resolution may be simple and specific to the grievant, or there may be a need for a systemic change to correct the issue to benefit the patients and could really impact all the patients involved in the facility. So I want to introduce you to the patient services team. This telephone number up top here, this is the number for our entire program, regardless of what network you reside in. This is a central call center. We use it called Ring Central, where you can get our staff at this phone number. And I do apologize for the typo. Our patient services director is Agata Raskowski. She is the director and leads our whole team here and our team members. She addresses the grievance cases specifically for Network 1 as well. Our patient services coordinator, Shazina Andiapan, is our lead for our Network 2 grievance and access to care cases. In Network 6, our patient services coordinator is Brooke Andrews. And for our Network 9 service area, our patient services coordinator is Elizabeth Lanez. And then we also have Julia Detman, who is our patient services coordinator, who supports all of our ESRD networks. And she also has emergency coordinator responsibilities. And we'll talk about that in just a few moments. But I really want everyone to make note of that phone number. Though it has a 516 New York area code, that's where our corporate office is. This is the phone number to reach any of our patient services staff about access to care challenges, facility concerns, and where our patients as well will reach out to file a grievance. So I'll tell you a little bit about the network role in patient experience of care, and we can assume one or more of these different roles when we're dealing with a situation, when we're representing patients or caregivers. So we can be a facilitator. We want to mediate the concerns that are raised and help to understand and open up communication. We can be an expert investigator, and this is where we might need to do a little bit more of a deep dive in understanding what the situation and concern is and how the problems can be resolved. We want to be an educator and making sure that all the tools and resources that have been developed to improve patient experience of care are available and out there for the community, not just the staff, but also the patients. And we're going to advocate on behalf of patients about access to care. And we'll go through what some of those scenarios are that might look like. For Referral Source, sometimes we do need to refer the patient or facilities to different resources to help report those concerns. Like I said, sometimes they're out of our jurisdiction. If it's a physical environment situation, that's not something that we go out into the community to investigate, but the state health department might be involved in something like that. And then also leveraging our quality improvement team and being specialists in that area when there are situations that involve the quality of care or the clinical care of a patient, then our social workers will refer to our quality team to be able to assess some of those situations. There are 3 different categories in or classifications in which grievances come into the network. So those are called immediate advocacy cases, and those are ones that we can resolve within 7 days' time. They are typically, or always rather, not clinical based situations. They might be something like a chair is broken, it's too cold in the facility, something that could be quickly turned around by talking with facility staff and making sure that the grievant feels like there's good resolution quickly. A general grievance is a concern, also non-clinical, but it might be a little bit more complex. It might need us to look at some progress notes or review records of the patient care, and we can resolve those in 60 days or less. And then those really complex cases that do involve something clinical in nature, those are our clinical quality of care cases. We do review clinical records back at least 3 months. We bring our ESRD nurses that are on staff into those cases, and sometimes even the medical review board. Those cases also need to be resolved within a 60-day period. So I just want to show some numbers. This is really just our calendar year so far, January to May, and the types of cases, those 3 categories that I had mentioned that we've been receiving in our program. So 96 cases total. If you can see, obviously there's going to be relevance to network 6 and 9 having a lot more cases in some areas because they are our larger networks. But, here you can see that our general grievances tend to have the most in that area, but right quickly behind it, we can resolve some of those grievances pretty quickly with 37 cases. And then a small number of quality of care cases where a patient might come to us or a care partner and say, you know what, I'm not feeling great. I just want to understand more about why I'm not feeling so great. And that's when our clinical team will investigate. We have a slew of resources that are available to patients and also facilities about understanding grievances, a brochure here about the grievance process. We also have posters called Speak Up, and this is important for patients to understand how to be able to reach the network. And we do hope that all of you have your state-specific Speak Up poster that's available within your lobby or your visitor area. If you don't, please reach out to the network and we'll make sure you get the link for that. Also can be found on our website. More resources here about a grievance process guide. It's really a flow chart about whether or not the grievance has certain criteria and who should they contact. There's a grievance toolkit. Even this Q&A in the center here is for dialysis facilities, just to kind of understand how to, you can augment your own grievance process internally. We want to make sure that there isn't any retaliation that's occurring. There also are V tags in the conditions for coverage that really talk about the responsibility of the facilities with regards to grievances and access to care. And then we have this great resource about dialysis facility involuntary discharge guidelines. And I'll just talk about IBDs in a second, and really what you can and cannot do, or what's responsible of the facility to support patients through access to care. So let's talk about that. There are 2 types of access to care cases that we have when they come into the network. So the first classification is an at-risk involuntary discharge, or what we call IVDs. And this is really when a facility will reach out to the network and there might be a patient that is disruptive, or they are, maybe even non-compliant, and we're worried about, you're worried about whether or not they're going to stay in the facility. So they haven't been discharged yet. You're really just contacting the network to give us a heads up. And then there's the IBD, or the involuntary discharge patients, which happens either immediately or within a 30-day period. And this volume is really closely monitored by the network and also CMS. So a couple of things to consider before an IBD happens, and really what the facility's interdisciplinary team should be doing. And you want to make sure that you're conducting a thorough assessment of the situation. And that you really understand all of the parameters about why an IBD may occur. You want to develop a plan to address the problems or barriers that are currently happening at the facility. And that plan is going to help support the team to be consistent in their processes. And I have on the bottom of the slide here, this is really important that, discharging a patient for non-compliance is not an acceptable reason. And that's really based on the CMS conditions for coverage. And I know that that's a challenge for many facility staff, especially with COVID and for a slew of other reasons, but you cannot discharge a patient based on non-compliance. And if you have spoken with our team, they will re-educate on maybe other opportunities to help support compliance, but certainly not a reason to discharge. So there are a couple of Ibd guidelines, though, that we want to make folks aware of. And the reason why, and I'll show data in just a moment, is because we have a very high number of discharges that have been occurring, especially because of the health crisis with the pandemic. But really important that you're notifying the network prior to any potential IBD or even a discharge notice is being provided to the patients. Because sometimes that notice has already gone to the patient, and say it's about non-compliance and you haven't talked to the network yet. And we're going to work with you to kind of pull that notice right back. So just please reach out to the network prior to any of that happening. And immediately notifying the network provides an opportunity for the network to review the issue and the interventions with the staff and see if there are other options that could be explored. We want to make sure you have a policy and procedures in place for IVDs, and it's important that staff are following a consistent process. So if you have one, please share that frequently with your staff. We want to make sure there's facility staff training that's occurring so that all staff receive training in conflict management techniques, and this hopefully will reduce IVDs. You're going to document everything. If you don't document it, it didn't happen, right? That's kind of the rule of thumb in healthcare. And if it's essential that staff document and address any and all problematic behaviors, no matter how insignificant they may seem, you want to make sure you have record of it and really how those situations are being handled. And that the IVD should be the last option when addressing difficult patients. An involuntary discharge can begin only if all efforts have been resolved or efforts have been exhausted to resolve the problem and that they failed, and that the issues and interventions to address them have been properly documented. So really important to make sure that that really is the last option. And then, of course, if it is the last resort and all you can do, the obligation is on the facility to assist the patients with placements. So please, we encourage staff not to just send the information out of where the local facilities are. We really need to support patients transitioning to another facility and becoming established with a new physician and really making sure that the information that goes to the facility is only the medical information requested. And I will say, once there is a blemish on a patient's record, it's really hard to get that patient placed. So, we ask that there's some confidentiality in what's shared with the facilities because they might actually have a better outcome at another facility. And then lastly, it's the responsibility of the facility to notify the state's health department. The network also is responsible for notifying the health department, and we will usually copy the team members on that. So just a couple of guidelines there. I do want to share the data here about the access to care case management. And there's a couple of things I want to highlight here. Everything that's in blue is really a subset of access to care. So facility concerns, when we're looking at facility concerns, these are actually phone calls that are coming from the facilities themselves to the network about those at-risk patients. And then the access to care, those are the ones that are in somehow either being discharged, averted, or we're failing to place them. So those three subsets of access to care are a breakdown of what is actually occurring. And if you look total, 177 patient situations of access to care is really just tremendous for those who are not either getting placed or not placed. Pleased to report there are many cases that get averted. And that's certainly thanks to many of you for helping to work with the patient and the network for the best outcome for the patient. But if you look at that involuntary discharge number, and particularly in our larger networks, 72 patients for our entire program were essentially removed from their regular care. And then 14 patients, we could not find placement for all. And I know for anywhere. I know that doesn't sound like a tremendous amount of number, but those 14 patients are probably in the hospital dialyzing. And in many situations, there's death that occurs because they're not having continuity care for treatment. So I just wanted to give an overview about access to care and grievances under our patient experience of care work. And really that all of you play a critical role in making sure that there is good experience of care that's occurring at the facilities. We certainly recognize there might be situations where they can get escalated or feel pretty intense, and we hope that you reach out to the network. We don't want anybody's to be jeopardized in their own safety, your staff and patients as well. But we are certainly here to help make yourself or to make the situation a lot better. I'm just going to pause for a second before I get into emergency management because I'm not monitoring chat. If any one of my peers can call out if there are any questions in chat I need to address.
There's a question. What are the main themes that you see for IVD and then reasons for non-placement?
Sure. And I'm actually going to open up the lines to my social worker peers. If you can answer that question, Agata Raskowski, Shazina, Brooke, Julia, anybody want to answer that?
Yes, so this is Agata, and I'm gonna respond back to the main themes that we are currently seeing, given the current situation with a lot of shooting that is happening that we see. We have noticed that there is an increase of involuntary discharges that are occurring based on verbal threats that is happening at the facility level. And yes, we do monitor that closely, and we are very sensitive to that situation. At the same time, we also, prior of the patients receiving that immediate discharge notice, followed by the network's contact, we would ask that the clinics are outreaching to us, discussing what are the circumstances behind those threats, if there's any interventions that we could put in place to the patients who might be already exhibiting behavioral challenges at the clinic. Those are the interventions that we are seeking when we are being in contact with by the clinic to report those situations.
Thanks, Agata.
Not a problem. With the non-payment situation, obviously there's a different layers of the non-payments, whether that relates to patients who do not have legal status. We have seen that very few clinics have accepted patients on pro bono status, where it's patients are not financially responsible for dialysis. But those are very rare situations. Mainly those patients are being then referred to hospital-based outpatient dialysis, where they can receive the hospital Medicaid, emergency Medicaid for dialysis.
Thanks for grabbing that last question. And I do see that there is a note here about for Network 2 where all of these cases can be addressed, and really that phone number that was provided for the patient services line. If you call that line, you'll get any one of our social workers, but specifically for Network 2, your contact is Shazina Andiatham, who is also on the slide deck. I do want to be mindful of time. I know we are at 3:28, and I want to get through emergency management pretty quickly with all of you. So hope you can hang on for just a little bit longer. I will say that the ESRD networks are the foundation of CMS's ESRD emergency management structure, and it's in collaboration with a national organization called the Kidney Community Emergency Response Coalition, or CASER. So they are the national coordinator or contractor to do that work from CMS, and that the network monitors conditions that might impact a facility's ability to provide services to dialysis patients, and that we work to mitigate risks, provide technical assistance to dialysis facilities, and help develop comprehensive emergency plans for facilities with facilities. The network also has established relationship with state emergency management offices. We have healthcare coalitions within our regions that we help to support. And during an emergency event, we work to identify challenges and barriers that impact patients and facilities, and then collaborate with the emergency response stakeholders at the local level to reestablish interrupted services as quickly as possible. So this slide here is all about how you can report when there's a problem. So if your facility's normal schedule is impacted by an emergency event, And it could be weather related, pandemic related, you have an altered schedule, your facility is closed because you're having staffing challenges. We want to make sure that we know about it. So there is an emergency operational status link on top of our website. So if you go to our website page, which is esrd.ipro.org, you'll see that little tag that says Emergency Operational Status Report. We want you to go into that link, and it's also here on the page, and tell us what's going on. And it's really important to do this because we report up to CMS. We also report to the state. If there's a big event that's happening, we want to make sure the state's aware of possible disrupted services. And then the Office of Emergency Management might need to be involved in that. We want to be able to assist in patient placement. So it's really important to understand that situation awareness. And then also, as part of our preparedness for the network, we conduct an annual critical asset survey with facilities, and this information collected is provided back to facilities kind of as the emergency summary report or your own operations policy. You can use this information. And this detailed report is also shared with the state emergency officials and the healthcare coalitions. And it helps part of their own regional planning. They want to be able to identify where there might be patients that need to have access to care and they're not understanding the census completely or what the capacity is for the facility. So all that information is shared with them. Again, the link is provided here. Right now, we're about at 88% completion rate. So of our 2,000 facilities, we have 1,752 facilities who have completed it. So I will say that you will be receiving facilities who have not had an opportunity to complete it. That due date was May 31st. We're going to be reaching out specifically to those facilities and even the large dialysis organizations to help complete that survey. It really is so important to have that information collected. Again, it can be part of your own emergency management plan for your facility, but it also helps the network and the state health departments and coalition members understand where the gaps might be, where we have to help out in certain circumstances. So if you received an email that there was no CAS or critical asset survey submitted, it might be because it was incomplete or what's considered abandoned, and you might even have the wrong CCN number entered. So we do just want to make sure that if you're receiving those messages, and I'm just going to flip back to this other slide again, that you do have the right link to be able to go ahead and complete that survey. We will be kind of finishing up that survey within the next couple of weeks, and we want to turn it around and distribute those facility summary reports out to everybody by mid-August. So really important that that is done. And I've kind of come to the end of our presentation here. I know I just ran a couple minutes over. I do hope that everyone found the information to be extremely helpful. There is a survey at the end when you do click out of this link for the webinar here. Your feedback is so important. Please provide that feedback to us. We're so interested in hearing how we can do a better job. And just a reminder, those presentations will be made available online, the presentation and also the meeting recording. I just popped that link in chat. But really, we thank you. We thank all of you for being collaborators and partners with the ESRD network program at IPRO to make sure that there is good quality of care and patient experience. We truly could not do our work without all of the hard work that's happening in the community. So I thank you for on behalf of the whole team here for joining us, and please feel free to reach out to any of these departments here if we can be of assistance to you. Thanks so much, everybody. Have a great day.